Ladies, come with me. Let him go. Let him go.
Mrs. White, we will take care of your husband as well as we can.
I'm wrong. Either way.
Ms. Daughter, do you have any paperwork about your father agreeing for his health care with you? Or can you call someone?
Listen to?
Clear.
Is everyone
clear?
Perfect.
Damn.
Good morning. My name is Elaine Crane, and welcome to the Mahogany team's Ethical Dilemma in the ER. Joining me are Susan Knowles, Heather Ungehauer, and Catherine Yu. What you just heard was how our case would sound and feel in real life. We will now take you through an ethical decision-making discussion to show the underlying choices that the ER team made in 24 seconds.
I'm going to step back from this situation and begin to discuss what just happened. As we present this case, please keep in mind that we are presenting it after the fact, attempting to learn from the situation. Rather than just explain this event in isolation, we'll attempt to discuss it from a wholeness approach, utilized in narrative ethics as debated in an article by McCarthy in 2003. Narrative ethics, according to Grace, 2014, is a way of learning from a situation. Additionally, as a framework for this discussion, we'll be using the steps and questions as presented in Table 2-6, entitled Ethical Decision-Making in Difficult Situations, provided by Grace 2014, and can be found on pages 82 and 83. Let's talk about our practice setting. According to our hospital website, Mountain View Medical Center, it's located in White Sulphur Springs, Montana, which is a rural integrated delivery system offering emergency services, hospitalization, long-term care, and a primary care clinic for the residents of White Sulphur Springs and Meeker County. Our full-time medical staff includes one medical doctor, one physician assistant, and one family nurse practitioner. Our emergency department is staffed 24 hours a day, every day. So imagine our surroundings: sparsely populated ranch land and National Forest Service land. We are a frontier community located 75 miles from the nearest stop sign. Because of this, Mountain View is in a unique position to provide services to a wide range of people. MMC is a vital part of the community, providing well baby checks, middle of the night emergency services, and meeting the needs of the elderly population in our long-term care. Mountain View Medical Center provides stabilization and determination of care and treatment, or transfer if needed. Transportation to another facility is provided by local ground ambulance or by air from either Great Falls or Billings, which means that Great Falls or Billings will send the air support. At Mountain View, our mission is to care for our neighbors, supporting them to live healthy, active lives, and helping them heal in times of injury and illness. We serve all who need care, regardless of their ability to pay.
Identifying the case. You see an elderly woman get out of the driver's side and walk around to the passenger side of her vehicle, where she attempts to try and help her elderly gentleman out of the car. You grab a gurney and call for help from one of the nurses sitting at the nurse's station on your way out the door of the ER entrance. As you approach the car, the woman explains that this is her 80-year-old husband. The couple has been at a family reunion at a local campground today, and her husband has been feeling poorly a majority of the day. As you approach her husband, you see that his color appears gray, and he seems to be fatigued, but he insists on getting out of the car himself. After he gets out of the car, you help him onto the gurney. We have no known medical history on this patient, where they may be traveling from. Are they traveling from another state, country, or perhaps they're just local?
As you wheel him into the ER, you notice that he has lost consciousness. Rapid assessment reveals no pulse or respiratory effort. As you call for more help and begin to prepare for CPR, his wife cries out, "Please don't do this. My husband has lived a long and happy life. He never wanted to take extraordinary measures to keep him alive." What are the triggers? the fear of the wife for her husband, the adrenaline that a code releases, personal thoughts and belief about end-of-life care, the measures we take to prolong life, needfully or needlessly. What are the assumptions? As healthcare providers, we must initiate life-saving actions as soon as possible. Someone also must stay with the wife to support her.
Moving along with the gurney, you look up and see a younger woman standing next to the gurney. The younger woman looks distraught. She says, "I'm his oldest daughter. I have power of attorney. You must do everything you can do to bring Daddy back." Are we in need of more information? But from whom? Yes, we do need more information, and from the daughter. We need to see the power of attorney. We need to know if it is properly executed and valid in the state of Montana. If the power of attorney is not valid in the state of Montana, we would then need to know Montana law regarding the patient's wife can make a decision to withhold life-saving actions. Per Post in 2009. Post also compels us never delay patient care to determine if the patient has pulse documentation. And finally, we need to make sure that the power of attorney or the pulse documentation is for medical decision-making and not for other aspects of care.
In this situation, time was of the essence. So who is the main focus? The patient is the main focus, which brings up the ethical principle of fidelity. Our duty is to our patient, the man, the husband, the father. We have very little time in this particular situation to stop and evaluate all the possible ramifications. Secondary persons of focus were the patient's wife and daughter. Additionally, potential unknowns could be other family members or dependents and perhaps even business or legal partners. The family, however, has convergent views and requests. Both his wife and daughter have an interest in the outcome and will be affected. Who else has an interest in the outcome? Well, the healthcare provider. If care was not rendered timely or correctly, then the healthcare provider may be found at fault. Therefore, the care provider has an interest in the outcome, regardless of the decision they make. Both ethical and legal parameters will guide their actions, and did so in this case. Also, there were institutional protocols that had to be followed, again related to legalities. The person also affected in this situation was the patient. What if he is brought back to a lesser quality of life?
Scientific evaluation has shown that there are no clear-cut criteria to predict the futility of CPR accurately. Therefore, it is recommended that all patients in cardiac arrest receive resuscitation unless the patient has a valid DNR order, the patient has signs of irreversible death, such as rigor mortis, decapitation, or dependent lividity, or no physiological benefit can be expected because the vital functions have deteriorated despite maximal therapy for such conditions as progressive septic or cardiogenic shock. CPR and other life support measures may be discontinued later when further information becomes available. Sometimes, within a few minutes of resuscitation being initiated, relatives or other medical personnel arrive and confirm that the patient had clearly expressed a wish that resuscitation not be attempted. Legally, we must start life-saving measures. According to Buford 2013, patients that are unable to communicate with no rapid access to current medical records could be done harm instead of good by withholding this life-saving measure. Our values were all similar in this nature. We did not want to bring him back to a more incapacitated life or being unable to live the quality of life he would wish for himself. Personal feelings aside, we would not want to revive him if that was not truly his wish. Or worse, if we bring him back and he has suffered a stroke or becomes a care or cost burden, who will take care of him at that point? Even if we feel like the wife would be more likely to know his wishes, we don't know that she's of sound mind as well. We have to start CPR, and we do not want to regret our decision later. It brings up the conflict of beneficence in regards to doing good and benefiting patients. But are we truly doing well or good when we're starting IVs and chest compressions and there are other complications that can be taking place?
There are many unknown cultural issues in this case. We do not know if the patient is a Jehovah's Witness or similar group, or if he has religious or cultural beliefs that would impact his care. We also do not have a neutral party to assist in the absence of his written wishes. In any emotionally charged situation, an ethical decision tree must be fluid and repetitive and adapt as the situation changes. Autonomy. In 1990, the Patient Self-Determination Act was passed. It stated that competent people could make their wishes known regarding what they wanted in their end-of-life experience when they were possibly not competent. Also included in this act is the durable power of attorney, which designates a competent person to assist in making end-of-life decisions when the individual was no longer competent. Fidelity. As nurses, we made a commitment to doing no harm and caring for the patient as a whole. Justice. Our patient has the right to our services. Paternalism. We do not know if the patient will survive in this instant, so we must act as we think is best for the patient. But the most important of these ethical principles in this situation will be discussed by Katie and Heather.
Non-maleficence, avoidance of harm or hurt. This is at the core of the medical oath and nursing ethics. Often in modern times, present day, non-maleficence extends to making sure you are doing no harm in the beneficent act of using technology to extend life or using experimental treatments that have not been well tested, as noted by Beauchamp and Childress in 2009. Multiple articles were written after the death of a patient, Mrs. Lorraine Bayless, in California in 2013, where a nurse refused to initiate CPR after calling 911. The statement, nurses need to know that by being a nurse, they are held to a standard different from the average person's, a standard that requires CPR when they are at work and encounter a patient who needs it, is quoted in most of the articles. It is not a legal standard, but an ethical standard, as noted by Bupert in 2013. For our patient, we would start CPR until paperwork is authenticated. If authenticated, we would stop. If not, continue on. As a healthcare provider, we would be found at fault for not providing care, especially since the patient arrived to the hospital. Once CPR has started there, it is the possibility he would be brought back against his wishes, or he could be altered medically from the code. Though if we do nothing and do not initiate CPR, we are at fault for withholding life-sustaining care that could have saved him. Can safeguards be put into place to prevent unforeseen consequences? If DNR and all life decisions were on a universally accessible EHR, we never have to face this problem.
Beneficence talks to the compassion and taking positive action to help others, desire to do good. A core principle